Welcome to the Deep Dive. Today we are immersing ourselves, really getting into the nuts and bolts of psychiatric care. Understanding the family system. It's funny, in a culture that really prioritizes individual autonomy, finding yourself, it's actually easy to forget that nobody exists in a vacuum.
Precisely. And that's the core message of this deep dive, isn't it? And we're focusing on family interventions from the source material. And while we celebrate the individual, the fact is we are profoundly defined, supported, and sometimes, let's be honest, damaged by our relational systems.
Yeah.
The family, it's not just a random group of people. It's the primary, most powerful social unit. It shapes our beliefs, our actions, really across our entire lives.
And we know that structure is always changing. I mean, we're way past that 1957 idea of the nuclear family.
Oh, absolutely. Long gone. When we talk about intervention now, you have to think about the whole spectrum. Single-parent families, blended ones, people cohabitating, extended families living together, grandparents raising grandkids, all sorts. So our approach has to be flexible. It has to recognize that the function of the family is really much more critical than its specific form.
Okay, so our mission today is pretty clear then. We're taking the essentials from this chapter on family interventions, and we want to turn them into practical, usable knowledge for you.
Right.
We're going to look at what healthy families do, those core functions. We'll unpack key therapeutic ideas like the identified patient, triangulation, and then really focus on the nurse's role, assessment tools, psychoeducation, all of that. So let's start with the basics. What does a healthy family actually do? #have I, the 5 essential functions of a healthy family. Okay, our source points to 5 key functions. Think of them like tools that healthy families give their members for success, both inside the family and out in the world. They are management, boundaries, communication, emotional support, and socialization. Let's start with management.
Sure. Management, well, it covers the practical stuff. How decisions get made, how power is shared or not shared, who makes the rules, how are resources like money, time, even attention, how are those allocated?
Right.
In a healthy, adaptive family, the adults usually work together on this. It's a partnership.
But the danger zone is when stress or dysfunction makes those roles shift inappropriately.
Exactly. You see this so often. Maybe a single parent is completely overwhelmed, or maybe a child gets pushed into adult roles way too soon.
Like making financial decisions.
Yeah, like a teenager having to figure out complex money choices, deciding maybe between paying the rent or the electric bill. Sure, they might learn responsibility, but it's at the cost of their own childhood needs, their development.
And that kind of mismanagement, I imagine, directly impacts the next function.
Yeah.
Boundaries.
Absolutely. Boundaries are, well, they're like these invisible lines. They define who's who within the family, separate individuals, and they also separate the whole family unit from the outside world.
So they provide structure.
They are the structure. They define who's responsible for what. Honestly, you can often tell how healthy a family is just by looking at their boundaries.
Okay, let's use Minutin's framework here. If a family has clear boundaries, what does that look like day to day?
Clear boundaries are adaptive. They're firm, yes, so everyone knows their role. Parents lead, kids follow, generally speaking, but they're also flexible.
Flexible how?
Well, they allow for negotiation, they encourage individual growth, let members develop a strong sense of self while still being connected. It's a healthy balance.
Okay. And then when those boundaries aren't clear, when they sort of blur together, you get diffuse boundaries?
Diffuse boundaries.
Yeah.
Yeah, these are tricky because they lead to what we call enmeshment. It's this intense over-involvement.
Everyone's in everyone else's business.
Pretty much. Identities get blurred. If one person feels pain, everyone feels it really intensely. And that often stops the original person from actually sorting out their own issue.
Yeah.
And this kind of system, it actively discourages differentiation. That's the vital skill of developing your own strong, separate identity while still staying emotionally connected to your family.
So trying to be your own person is seen as bad.
In a highly enmeshed family, yeah, expressing separateness, wanting something different, it can feel like disloyalty, like you're betraying the family unit.
That sounds like a terrible bind.
Yeah.
The push to be yourself versus this pull to stay loyal. And the opposite extreme from diffuse is rigid boundaries.
Right. Rigid boundaries are like iron walls. They demand strict adherence to rules, often unspoken rules that never change. And the result is disengagement.
Disengagement. So isolation.
Pretty much. Communication is minimal. Sharing emotions is rare. Members often end up living these parallel, sort of isolated lives within the same house.
And the impact long term.
Well, individuals from these really rigid families often struggle with intimacy later on. They have trouble forming close bonds because they never learned that give and take, that emotional closeness growing up.
Okay, that makes sense. Moving on to how the system actually operates day to day. Communication. Our source highlights a kind of golden rule. Be clear and direct in stating what you want and need, preferably using I statements.
Yes, I feel, I need. But in dysfunctional systems, that clarity gets lost. It's replaced by strategies, often unconscious ones, to avoid conflict or maybe avoid taking responsibility.
What kind of strategies?
Oh, you see all sorts. Manipulating, trying to get needs met indirectly, maybe playing people off each other, distracting, changing the subject when things get tense, generalizing, using always and never. You always do this. You never listen.
Very blaming.
Exactly. Outright blaming is another one. And also placating, where someone just tries to smooth things over, keep the peace, even if it means sacrificing their own needs or feelings.
Now, here's a term that comes up that feels really important for anyone listening who's heading into clinical practice. The double bind. It sounds like a trap.
It absolutely is a trap. It's when someone consistently gets two or more conflicting messages. And the key thing is the mismatch.
Mismatch how?
Usually you get one message that's verbal, maybe sounds positive, but it's immediately contradicted by a second message, often non-verbal body language, tone of voice that's negative.
Can you give us an example, something that really shows the emotional impact?
Okay, think about a mother saying to her teenager, "Go on, have fun at the party, make lots of friends." Sounds good, right?
Yeah.
But while she's saying it, she's maybe gripping the teenager's arm really tightly. Her eyes look wide with fear. Her whole body is practically screaming, "Don't leave me alone."
Okay. The words say one thing, the actions say the complete opposite.
Exactly. The positive verbal message is totally canceled out by the negative nonverbal one. And the teenager, they can't win. If they go, they feel guilty, disloyal. If they stay, they're miserable and resentful. They're just stuck, immobilized by anxiety, and that anxiety often comes out later as other symptoms, emotional or behavioral problems.
Right. That makes that classic textbook example, be spontaneous, finally makes sense. You literally can't be spontaneous if someone tells you to be.
Precisely. The instruction itself creates the trap. It's a paradox.
Okay. And finally, just briefly, the last two functions, emotional support and socialization.
Right. Emotional support is about creating that safe, nurturing environment where members feel secure enough to grow, to try new things, explore different roles.
And socialization.
Socialization is mostly learned through role modeling. Parents teach social skills, how to negotiate, how to plan. And crucially, the system needs to be flexible here, especially when roles change naturally over the life cycle.
Like kids leaving home.
Like kids leaving home, parents retiring, illness, big life shifts. Rigidity during those transitions, that's a major trigger for family crisis. Flexibility is key. #2, central concepts and models of family therapy.
So when a family does decide to seek help, the goals are usually twofold, right? Improve individual coping skills, but also strengthen how the whole family system functions.
Exactly. But often, the first challenge is figuring out where the real problem lies. And that brings us to the concept of the identified patient, or the IP.
The IP, that's the person the family points to as the problem.
Yes. They're seen as the symptom-bearer, the one who needs fixing. But from a therapeutic standpoint, we look deeper. We recognize that the IP's symptoms, their anxiety, their acting out, whatever it is, might actually be serving a purpose for the whole system.
Serving a purpose. How so? Like the illness is doing a job.
In a way, yes. The IP's behavior might be unconsciously working to stabilize the family. Maybe it distracts everyone from a really rocky marriage or deep financial stress.
So the IP is kind of sacrificing themselves to keep things calm.
It can look like that. They might sacrifice their own development, their own autonomy to hold the system together, to divert attention from those deeper, maybe unspoken issues. The symptoms maintain a kind of fragile balance for everyone else.
Wow. And this idea connects directly to triangulation, doesn't it? Which often keeps that IP role going. We know that two-person relationships, dyads, they can be unstable under pressure. So when anxiety builds up,
When that dyad gets too tense, the anxiety needs somewhere to go. So a third person, or sometimes even an object, a pet, an issue gets pulled in. That creates a triangle.
and triangles are more stable.
Structurally, yes, because they divert the tension. Communication gets routed indirectly through the third point, lowering the immediate heat between the original two. But that temporary stability comes at a huge emotional cost, usually to that third person who got pulled in.
Let's use this source's example here. Charlotte, the youngest child. She senses the tension simmering between her parents, Amanda, and Andrew.
Right. And when Amanda gets frustrated with Andrew, instead of talking directly to him, she vents to Charlotte, complains about him to her.
So Charlotte becomes the mediator.
Exactly. The mediator, the confidant, it's a role that's totally inappropriate for her age and position in the family. And the long-term damage, as the source suggests, is maybe Charlotte feels, even subconsciously, that she can't leave home for college.
She gives up her dream school.
Maybe she chooses a local community college instead because she's worried her parents' relationship will just fall apart if she's not there to run interference. She's basically sacrificing her own future path to keep their presence stable. That's how destructive chronic triangulation can be.
That's powerful. Now, as nurses, especially generalist RNs, we might not be the ones conducting formal family therapy, like structural or family of origin therapy.
Right, that's typically for advanced practice nurses with specialized training.
But we still need to understand these models, don't we? For context, for making appropriate referrals.
Absolutely. Knowing the framework helps you understand the therapist's focus. Structural therapy, Minuchin's model, is all about fixing those boundaries we talked about, clarifying the family hierarchy. Who's in charge? Are the lines clear?
Okay.
Family of origin therapy, Bowen's approach, looks more at the past influencing the present. It focuses on lowering emotional reactivity, helping individuals differentiate, become their own person while staying connected.
And there's also the contextual model.
Yes, Buzzerman Yanagi. That one really dives into things like loyalty, family legacies, ethics across generations. It talks about balancing the emotional ledger, what's owed, what's given, emotionally speaking, within the family history.
Okay, let's shift gears now specifically to the nurse's role. Applying these concepts, first step, assessment. You can't figure out a complex system without a good map, and the main mapping tool here is the genogram.
The genogram is fantastic. It's such an efficient clinical summary. It lets you map out family structure, relationships, and functioning across at least 3 generations.
3 generations, okay.
Yeah. It uses standard symbols, squares for males, circles for females, shows who's related to whom, but then it layers in really crucial information. Demographics, dates, major life events, and importantly, functional status. Medical issues, emotional problems, behavioral patterns.
And critical events, too, like separations, deaths, major illnesses.
Exactly. You can mark divorces, suicides, chronic conditions like addiction or depression. It basically gives you this rich visual snapshot of the family's history, both medically and emotionally, all in one place.
So let's try to visualize this. Walk us through the Kate Smith vignette from the source using the genogram concept.
Okay. So Kate is a 17-year-old identified patient. She's brought in because of conflict with her mom and marijuana use.
Right.
So on a genogram, you draw Kate, a circle, then you map her parents. Her mother, Catherine Circle, has generalized anxiety disorder, GAD, you'd note that. Then you go up a generation. Catherine's mother, Sylvia, Kate's grandmother, died young by suicide. You'd mark that tragedy.
Wow. Okay. Heavy history there.
Definitely. Then you look at the father's side. Kate's dad, Hank Square, has major depressive disorder. Note that. And Hank's father, Kate's paternal grandfather, died early from a heart attack and MI. Mark that too.
So just by mapping it out, you immediately see this pattern, this history of emotional distress, anxiety, depression, suicide, and also physical risk, like the early heart attack.
Precisely. And then you add the current dynamic. Kate is described as trying to run interference between her divorced parents.
So the triangulation is visible too.
It suggests it very strongly. The genogram helps you hypothesize that Kate's current symptoms aren't just about her. They're likely the latest expression, the current flare-up of this multi-generational pattern of untreated or maybe poorly managed anxiety and depression.
Yeah.
It shows the cycle.
That's incredibly useful. Now, this kind of deep dive into family dynamics brings up a really critical point for nurses, self-assessment. Because we all come from families, right? We have our own histories, our own patterns. So we're actually pretty vulnerable to getting pulled into the patient's family system, getting triangulated ourselves. What's the big red flag? How do you know if you're getting sucked in?
The number one sign, the gut check, is feeling an anxiety level that is greater than the situation objectively seems to warrant.
So feeling overly worried.
Overly worried, overly invested in a specific outcome. Maybe finding yourself strongly siding with one family member against another, or feeling really uncomfortable when, say, a parent tries to complain to you about the patient instead of talking to them directly. Those are major warning signs you're getting drawn into their triangle.
Okay. And the way out, the professional response.
Direct communication. Always. You have to gently but firmly redirect them back to each other. Encourage direct conversation between family members. You're essentially modeling and reinforcing those clear boundaries, even in how you interact with them.
Right. Maintain your professional boundary.
Okay.
So assessment's done, self-assessment's done. We move to nursing diagnosis. Lots of possibilities here. Impaired family processes, caregiver role strain, maybe a relationship problem.
Sure, those are common.
But the source emphasizes that the absolute planning priority has to be safety needs, first and foremost.
Always. Before you address anything else, you have to assess, is there any immediate risk of suicide? Is there potential for abuse, physical, emotional, sexual? Is there a risk of aggression towards others? Safety trumps everything. That dictates your immediate actions.
Okay. And that brings us to intervention, specifically what the generalist RN can and should be doing. The most powerful tool seems to be family psychoeducation.
Absolutely. This isn't formal family therapy, remember. It's a practical, problem-solving intervention. It helps families deal with immediate crises, but also builds skills for long-term coping.
So what does that look like in practice? What specific things does the nurse do during psychoeducation?
Well, first you provide clear information, jargon-free, about the illness itself, what causes it, what the typical course looks like, why certain treatments are recommended. You explain the rationale.
Okay, information is key.
It is. Second, you teach practical coping skills. Things like stress reduction techniques, maybe better communication strategies, and importantly, particularly for families dealing with severe mental illness like schizophrenia, you teach them about expressed emotion.
Expressed emotion, that's the criticism, hostility, over-involvement.
Exactly. High levels of expressed emotion are strongly linked to relapse. So you help families learn ways to communicate supportively without that negativity or intensity. It makes a huge difference to stability.
What else?
You also teach families to recognize prodromal symptoms, those subtle early warning signs that might indicate a relapse is starting. If they can spot those early, they can get help faster, maybe prevent a full-blown crisis.
Catching things early. Makes sense.
And finally, you empower them. Help them connect with community resources, support groups like NAMI, for instance. Help them develop a concrete relapse prevention plan. It's about sharing knowledge clearly, giving them tools. But just as importantly, it's about listening.
Listening to everyone.
Listening actively to the perspective of each family member. Often, just having someone hear them out helps the family realize they're all under stress, just experiencing it differently. It can foster empathy within the system itself. #outro. So if we tie this all together for you, the big takeaway is that an individual's health is just inseparable from the health of their family system. Remember the importance of those clear boundaries, that balance between connection and autonomy, that push for differentiation.
Yeah.
And keep those key analytic concepts in mind. The identified patient might be stirring a function, stabilizing things. Triangulation offers short-term relief but causes long-term problems. And your go-to assessment tool, that genogram, map out those 3 generations.
We started this by noting how our culture pushes for individual identity, but this whole deep dive really confirms how much we're shaped by the systems we come from.
Absolutely.
So here's a final thought for you to consider, something that builds on this. We briefly touched on how cultural context matters, like the example of the Amish community, with its typically more rigid roles and high value on group loyalty.
Context is everything.
Think about this. How does that deep cultural context change your approach as a nurse? If you're working with a family where differentiation, becoming your own person, is culturally viewed as almost hostile, as a betrayal,
Right.
your first intervention can't just be pushing for autonomy, can it? You might need to start somewhere else entirely.
Exactly. You'd need to focus first on building trust, validating their sense of connection, respecting the loyalty and legacy that holds that specific family system together. Only then, maybe, could you start gently exploring possibilities for subtle shifts in boundaries or communication. It requires immense cultural humility.
A really vital reminder. All our interventions have to be culturally informed, ethically grounded.
Well, thank you for joining us for this deep dive into family interventions. We genuinely hope this knowledge helps empower you in your practice.